back to Paramedic Project. Thanks for joining us once again. Today, joined by a guest presenter, friend of mine, friend of the show as well, Dr. Paul Everett, emergency registrar. And from my perspective, Paul's in a really unique situation because he's got a whole lot of experience with ambulance, worked as a paramedic at all different skill levels, plenty of time as a critical care paramedic, plenty of time as a flight paramedic, and then at the end of all that experience, still super passionate about emergency medicine.
Yep.
So I decided to take the leap and go through medical school and is now out working as an emergency registrar. So today Paul's going to share insights on the importance of clinical handovers. And I'll just sort of paraphrase the three big points we're going to cover today. First of all, that this is a learnt skill. Second of all, it's a mechanism for the transfer of the care of a patient to a medical service.
Yep.
And third of all, that for that mechanism to work really well, it needs to be structured, it needs to be concise, and it also needs to be systematic. So let's flesh out those points a little bit more. First of all, the one on learnt skill. So what's your practice around giving a handover? What do you do these days when you're delivering a patient, maybe from a helicopter to an emergency department, to a trauma service, or what's your practice?
Or even on a ward round? My practice is to practice.
Okay.
It isn't a learned skill. It is a learned skill. This is something you need to work at. It's something that I started as a student ambulance officer, and I would have it in my notebook and I would have the structure written down, and prior to getting to hospital, I would work through and do this.
Okay.
And I still do it now. We do a ward round prior to the end of each shift, or a couple of times through ward round the shift, and I will still do a walk around the ward so that when I go around with the consultants, I know exactly what is going on with each patient. And this isn't just so that you can look good in terms of what you're doing, but because a handover is a reflection of the patient care that you've done so far. It's about knowing what you've got going on for your patient and making sure that the continuity of care is there.
Yeah.
So I will practice. If I do a transfer across from one hospital to the next, I will sit down with the notes, and prior to getting to that hospital, I will run through that 3 or 4 times.
Yeah. And I suppose my practice around that is pretty similar. I always have a point where I'm pulling into the hospitals either a couple of blocks from the hospital or a kilometre from the hospital, or pulling into the driveway of the hospital where I'm going through the points that I want to hit, the exact structure of that handover. Actually, before I go in, it's like a dry run, just like we had before this episode, a dry run of the actual handover of the patient, just to make sure that all that information that I've received caring for this patient for an hour or so is conveyed really well in that couple of minutes.
Yep, exactly.
Yeah, so that's the whole process. So that's it, and that takes time. It's a learnt skill. You need to do it on every patient, and for us ambulance or paramedics, those low acuity patients, I kind of use them to practice and hone this skill. Practice and practice, so that when we get the really sick patients, that skill, that learnt skill of the clinical handover is really concise, and we can just bash it out really well when we need to.
I did hear an expression once, and it says, train hard, fight easy.
Okay.
And whatever you do, train hard so that when you get that really sick patient, you can hand over fluently.
Yeah.
So practice on the low acuity patients and get it right.
Yeah, and that's all skills, I think, in the pre-hospital environment, but especially clinical handovers.
Yeah.
Okay. So second point was it's a mechanism to transfer the care of the patient to actually a medical service. So points on that, and we've sort of touched on some of them already, I think.
I think so.
Yeah.
But remembering that as a paramedic, you've had this patient for an hour or so, and you're synthesising information that somebody has to absorb and then continue their care in a 2-minute segment.
Yeah.
So you've had a lot of time to digest, to synthesise, to tease that information, and then you're going to drop it on them in a 2-minute window. So it needs to be informed, it needs to be concise, it needs to be accurate, and it needs to be structured so that they can do that.
Yeah, and you made the point before that we might have had 1 or 2 patients in an hour, but if you're handing over to a triage nurse or even an emergency reg in a really busy ward, like how many patients is the average triage nurse kind of seeing past their eyes?
Maybe, in an hour, they might see 20 or 30 patients come past them in an hour if they're in the ambulance section, and if they're at the front desk, then a lot more than that. Yeah,
so that information really needs to be concise and needs to be conveyed within in a couple of minutes. Yeah. Okay, and then the third point we talked about this handover being structured, systematic, and also accurate as well. Yeah. So what's the structure that you kind of use for medical patients? We're talking here.
Yeah. For medical patients, the hospitals tend to use the S-bar, but you can manipulate it to whatever works for you, as long as it fits those key features earlier on, but
Yeah.
SBAR, so situation, what's happened, the background, where does your patient come from, what is the story that sits behind it. A, for assessment, what do you perceive has gone on, what have you gained in terms of information, and R, for response, or how have they responded to your treatment, what interventions have you done.
Okay, fantastic. So that's sort of the three big points, I suppose, to introduce clinical handovers. And next episode, maybe the next couple, Paul will be joining us once again just to flesh out that structure a little bit more, provide some examples on real-time patients, and talk about how that differs for patients in, I suppose, different medical states and also different states of medical duress, I suppose. Yeah. So please join us once again. It's been Paramedic Project. Thanks for joining us. Find us on social media. See you next time.
See ya.